Treatment of metabolic acidosis involves addressing the underlying cause, restoring acid-base balance, and preventing complications. The approach depends on the severity of the acidosis, its duration, and associated conditions. Below is a detailed overview. Strategy 1. Identify and treat the underlying cause. Effective management requires addressing the root cause of metabolic acidosis. Common causes include diabetic ketoacidosis, DKA. Administer insulin, fluids, and electrolyte replacement. Lactic acidosis. Improve oxygen delivery, e.g., oxygen therapy, treating sepsis, correcting hypovolemia. Renal failure. Optimize renal function. Consider dialysis if severe. Toxic ingestions. Use specific antidotes, e.g., fomepizole for methanol ethylene glycol poisoning, and support measures like dialysis. Diarrhea. Loss of bicarbonate. Rehydrate with fluids containing bicarbonate or lactate. 2. Supportive measures. A. Fluids and electrolytes. Correct dehydration. Administer isotonic fluids, e.g., normal saline, to restore circulatory volume and improve renal perfusion. Potassium correction. Monitor potassium levels. Acidosis causes extracellular potassium shift, which may mask true potassium depletion. B. Oxygenation and ventilation. Ensure adequate oxygenation to reduce lactic acid production. Mechanical ventilation may be needed for severe respiratory compromise. 3. Bicarbonate therapy. A. Indications. Severe metabolic acidosis, pH 7.1, not rapidly reversible by other means. Life-threatening symptoms such as arrhythmias or hemodynamic instability. B. Administration. Sodium bicarbonate is infused carefully to avoid complications, e.g., hypokalemia, hypernatremia, or paradoxical CNS acidosis. Calculate bicarbonate dose. Dose, MEQ base deficit, times text weight, time 0.3. Administer half the dose over several hours while monitoring closely. C. Risks. Overcorrection leading to metabolic alkalosis, increased CO2 production, worsening intracellular acidosis. MA4. Renal replacement therapy, RRT, for severe metabolic acidosis due to renal failure, toxin accumulation, or unmanageable electrolyte imbalances. Dialysis may be required, e.g., hemodialysis or continuous renal replacement therapy. 5. Treat specific causes. Toxin-induced acidosis, dialysis for methanol ethylene glycol poisoning. Hyperchloremic acidosis, discontinue or adjust chloride-rich fluids. 6. Monitor and prevent complications. Frequent monitoring. Regularly assess pH, bicarbonate levels, lactate, electrolytes, and renal function. Address complications. Manage complications such as arrhythmias or hypotension. Key considerations. Acute versus chronic. Chronic metabolic acidosis, e.g. in CKD, may require oral bicarbonate supplementation. Pediatric patients. Special care is needed to avoid rapid correction of acidosis, which can cause cerebral edema. Individualized treatment. Consider patient-specific factors like comorbidities and medication use. Conclusion. The management of metabolic acidosis is multifaceted, requiring a targeted approach to the underlying cause, judicious use of supportive therapies, and careful monitoring to ensure patient safety and recovery.